The authors have no financial interest.
This is a case of a Morgagnian cataract with a small pupil. You can see that I am putting viscoelastic and then I am putting iris hooks to expand the pupil. Once I do that, I paint the surface of the anterior capsule with trypan blue, then make the main incision and go ahead with the capsular excess. The capsular excess is really a challenging problem in Morgagnian cataract because of the lack of the support and also because of the universal zonulopathy which occurs in Morgagnian cataracts. I had a lot of difficulty in doing the capsular excess. Initially started with the needle and went round with the capsular excess forceps, but fortunately for me I was able to complete a good capsular excess. Phacoing this small Morgagnian nucleus is so difficult in the bag, so we have to think of something different. So I thought of doing what is called IOL scaffold. I brought this nucleus up and then I created a space underneath the nucleus. You can see that capsular excess is there, the entire posterior capsule is intact, and pushed in a lot of sodium hyaluronate and then injected a single piece lens into the bag. This lens acts as the scaffold so that I'll be able to remove the nucleus without any problem. I tried to attempt the nucleus removal, but unfortunately for me, vitreous started presenting into my phaco tip through the zonules and through the tear in the PC as well. So went ahead and tried to put this haptic, the trailing haptic, into the bag, but could not succeed. The whole bag was getting distorted and I had to do an anterior vitrectomy to remove the vitreous which is there posterior to the IOL in the pupillary area. Then went ahead and removed the one of the iris hooks, and now I am in double trouble because I have the nucleus as well as the lens. So I brought the lens up so that the nucleus does not go back, and used the vectis to remove the Morgagnian nucleus out of the eye, and then removed the IOL as well. And since the anterior capsule was intact, after doing an anterior vitrectomy using preservative-free tricot, I was able to put a multi-piece lens in the sulcus and then remove the iris hooks and put the sutures for the main port. And the patient had good 6/9 vision post-operatively. Another case wherein IOL scaffold can be very useful. This is a patient wherein an IOL exchange has to be done because of the wrong power of IOL which is implanted. So I brought this IOL which has to be explanted. I used a good viscoelastic to fill in the bag, and then I put a lens into the bag which acted as a very good scaffold. The reason why I am putting this is because when I am cutting this lens to explant this lens which I wanted to remove, I don't have the fear of damaging the posterior capsule. The lens has been cut into two halves and then removed to the same small 3 mm incision, and this patient also did well. These are two examples of an IOL scaffold which can come to your rescue when there is a PCR or when there is a Morgagnian cataract and when you want to do an IOL exchange.